Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here with Dr. Jay Calvert, looking spiffy. I would say as usual, but as unusual, except for last week. You're still rocking the collared shirts these days.
Yeah. I still got some. I've got a kaleidoscope of colors on the lower neck region. Interestingly, near the external jugular veins on both sides.
Where you were assaulted, unfortunately.
It's okay.
A few weeks ago. But, 2 weeks in a row, you're wearing the suit. You're looking spiffy. I'm enjoying it. I like the whole fit you have going here. So
thanks. And, this is also for our session, which we will be taping. The 250th episode. So, I don't want to tease it, but it's coming.
A little teaser. This is episode 249. We have 250 coming up, and it's going to be pretty special. So
it's going to be cool.
Yes, we are excited. So we're just going to say that you got dressed up for episode 250.
That's right. And we tend to record 2 or 3 of these at a clip. And so today we're on to breast augmentation.
Yes. So we have not done breast augmentation in a little while, and we do like to go back and revisit these every once in a while because, things change, and there's always updates and things that we can talk about. So this is going to be part of our 101 series, which we do every so often, which is where we really just trying to hit a core topic of plastic surgery at its most basic sense. We've done so many deep dives into all of the niche aspects of this surgery, and there are plenty of podcasts that talk about where breast implants go, the pocket, the style, the projection, what they're made of, how to choose a size. We have all sorts of categories. But this is just going to be sort of a catch-all, basic, this is what you need to know if you're thinking about having a breast augmentation.
Yeah, and I think the first thing to think about if you're somebody who's thinking about getting a breast augmentation is what's the goal? Why do you want to do this? And it could be for, I want my breasts to be bigger. I want them to be prettier. I want to take care of some sagging that I see. I want it to fill out the stretch marks that I had after pregnancy. There's so many reasons to get a breast augmentation.
Many reasons. And people may be surprised at that because I think the average person would think, well, if you want to have a breast augmentation, it's because you want your breasts to be bigger, duh. But not necessarily. Yes, that's a huge part of it. But then there's also the patients that have lost weight, the patients that have had babies and breastfed, and they just have a lot of loose skin. And they're not necessarily looking to be bigger than they ever once were. They just want to be rejuvenated, brought back to the breasts they used to have, and that may involve putting in an implant. You also have patients that have issues like tuberous breast or congenital breast asymmetry, where their breasts are either asymmetric in different sizes, or they just don't have a nice round shape to them because they were in development and they didn't develop quite right. And so they just want their breast to be round and look more like a breast and less, maybe oval shaped or something. So there are lots of reasons, actually, why someone may look into having a breast augmentation.
Yeah, and I think it's important to kind of know what your goal is. And I kind of say this about, I used to do kind of a joke about that, about, here's a great idea if you're going to the plastic surgeon and want to talk about aesthetic surgery. How about this? Have a plan. Know what you want to do. It seems simple, but a lot of patients come in and just say, "Oh, I just want to see what you think," or "I want to do this." That's really not a great way to approach it. You should kind of come in and say, "I'm thinking about breast augmentation because my breasts are this, and I want them to be that." And so here's what I'm thinking. And always having photos is really helpful in breast augmentation. Having a lot of my patients come in with an inspo folder on their phone, and they can flip through and say okay, check this out. This is what I look. Here's what I'm thinking about. And it is helpful because when people say I want my breast to be bigger, that can mean anything from going up half a cup size in bras to being as big as they possibly can.
Right.
And I just think that it is a really good idea to have an idea of what you want so that you can communicate it to your surgeon.
No, I definitely agree. I disagree on having a plan. My favorite patient is the one that comes in and says, this is what I would like. You tell me what I need to do to get there.
Sure.
I would way prefer have that. And I would prefer the person that's never even heard of the internet, never been on the internet to look all this stuff up, because that can be its all own rabbit hole of, well, I was reading about this and this and this, and then the profiles and the styles and the recalls. And it can be what should be a 30-minute consultation, 45 minutes at most, turns into like an hour and a half consultation. So in some ways, I almost prefer like the breast aug virgin who comes in and is like, you tell me what I need to know. But that's what this podcast is for. So let's tell them what they need to know about breast augmentation. So if someone comes in, they don't like their breast, they know they want implants, or they're just asking for input, and they're going to need implants for one reason or another. There are a couple places where decisions can be made. The first one, at its most basic, is what kind of implant? Saline or silicone? And a saline implant still has silicone. It still has a silicone shell on the outside. You're not completely removing silicone from your body, but the inside is filled with saline, salt water. A silicone implant has a silicone shell and silicone on the inside. Any implant placed today going forward has some level of what's called cohesivity. So that means that the silicone gel is more like a semi-solid as opposed to an ooey-gooey runny silicone of yesteryears.
Yeah, that's a big deal because people always say, well, what if it ruptures? I heard that the silicone can go throughout your body. That's really not the case anymore.
Not anymore. It used to be back in the 80s, 90s, that silicone was really runny. It could get into the lymph nodes. It could get into the breast tissue. Now, think of it like a gummy bear. You cut a gummy bear in half, that gel doesn't go anywhere. It kind of stays in its shell. So that's called a kind of cohesive or semi-cohesive silicone implant. And those are your two choices, saline or silicone. My preference is silicone. I think that they are more natural. I think they feel softer. I think they look better. And even if it does rupture, it's still safe and it's not a surgical emergency. If a saline implant ruptures, that's a surgical emergency because all of a sudden it's like a ruptured water balloon. That implant's deflated, it's gone, and you're totally lopsided.
I think emergency is a strong word because I've had these patients walk around for a while before they've been fine, but it looks funky.
It looks, I would call it an emergency.
I think if you're a breast connoisseur, it is an emergency.
It is an emergency.
She's got a rupture. Call the OR.
Stat!
Yeah, it is though, because the truth is you should get them fixed sooner rather than later because that pocket starts to close down.
Right. There are all kinds of reasons why
that's not good.
It would behoove you to have it fixed sooner rather than later. And the only other thing I'm going to say about saline implants, and then we'll move on, is that there are now some companies, some implant companies, I'm thinking right now of Sientra, that doesn't even make saline implants. I called them once because I'm like, I have a patient that really wants saline implants, and they laughed in my face. They're like, ha, 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 ha. We don't make those at all. So saline is kind of, weaning its way out, but there is always still going to be a cohort of patients that just feel more comfortable with them. So that's an option.
Yeah, no, and I think that's, I like the silicone implants a
Love
lot.
them.
I mean, when I was training back, when you were in diapers, we only had saline implants because the silicone implants had been taken out by a moratorium because there had been court cases that were, saying that these implants caused all these problems, which, the science has proven that they
was
don't.
not the case.
Now, I'm not saying that implants don't cause some people problems. They do. Some people cause the health problems, and that's a whole nother podcast. Please refer to our BII and all those other podcasts we've done about those topics. But in the end, the science came back and showed that the implants were safe and you could put them in. And then I got back to silicone implants around 2001, too, where they became sort of readily available. And now that's kind of what I use. I don't really, I think I had a saline patient who had saline implants from back in the day, wanted to stay with it because they've been fine and served them well. So there we go.
I know. I think the one thing that would be really indicative just to the general population is that if you were to poll plastic surgeons, female plastic surgeons that have breast implants, male plastic surgeons that have put implants into their wives, spouses, girlfriends, etc., I would say 99 out of 100 of those have put in silicone implants. So if that doesn't tell you something about how much we think that they are safe, then I don't know what else would.
Yeah, it's true. I mean, I prefer silicone implants, and they're in my family members and my my colleagues who I've done augmentations for, and they are really safe and they do really great. And as I always say, you can always have problems. Just because the 99.9% of the population hasn't had problems, it doesn't mean that you can't. It is the truth, and it's like anything in plastic surgery is that way. You have to recognize there are risks with surgery. anything can happen with anyone, but the data shows, and not only the data, just the experience of the surgeon that you're working with, they'll tell you, this is how I've done it, and the problems I've had have been, I've had capsular contractures, I've had, everybody's had one breast implant infection that they just don't even understand how it happened, and like those things do happen, but they're very rare.
They're very rare. So once you've come in and you've decided, that you've chosen your saline or your silicone implant, this is where it usually starts coming down to size. And along with size is sort of the profile of the implant. Those go hand in hand. This is where I really like for patients, like you said, to have photos. Because if I say, well, what size are you thinking? And they say, I want to be a C cup. In my mind, that means something. But then they show me these inspo photos of like these, triple D women. And I'm like, oh, okay, well, that's cool, but that's not a C cup or not what I was thinking. So that's where the photos are really helpful, because then I can look at that and be like, okay, this is what the patient's thinking. And the size is such a tricky thing. And we've gone over this over and over again. The size that you need as an individual patient is so dependent on you and your body, how tall you are, how much you weigh, how much of your own breast tissue you have, how much extra skin you have. All of these things come into play. So it's really hard if you come in and say, I want 350 cc implants, because that might not be what works best for you. And so the photos are helpful, because if you come in and say you're a 5'1" female and you show me photos of women with really large breasts, that might be a 500 cc implant for you. If you are a 5'8" female and you show me those same photos, well, now that's like an 800 cc implant for you. So don't get hung up on a number, especially the tall patients, because they may come in and you'll tell them you need 500 cc's and they're like, oh, that's huge, but not on you. So again, photos are helpful, and then that opens the discussion with the plastic surgeon about what size that would translate to for you.
Yeah, and on my Instagram, if you go, on the Dr. J. Calvert Instagram, there's a discussion that I had with Whitney Johns, who's a fitness person. She has her own fitness. She's got everything, supplements and personal training, and she's really taken the fitness industry by storm. And she came into me with just some really not good-looking 350 cc implants on a 5'10" woman,
right?
Who, her body is just, she's like, she looks like a superhero. She's ripped and she's in great shape. And she said, when she came into me and I looked at her, implants, I said, you need 500s at least, maybe 600. And she was like, that's crazy. Like, what are you thinking? And then, I kind of explained it to her. I said, this is, your body type. This is what you need. And this is a high profile. So it's narrow for your like, we fit it to her body. Mm-hmm. That's the key. And afterwards, she said, I would have gone even a little bigger. This looks great, but boy, I could have gone to 650 or something like that. I think if I went back, that's what I'd do. So just because you hear a number,
right,
and you've read on the internet, the internet has told you in some implant sizer program that you put your body type and blah, 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 and what you want. And they said, you need a 380 cc high profile gel implant. That may not be true.
That may not be true. And it also depends on how much breast tissue you have. If you have very little breast tissue, well, then you need more volume coming from the implant. Some women come in with fairly large breasts already, and they just need them perky or more rejuvenated. And sometimes a tiny 210 cc implant in these people is all that they need. I mean, anything more than that, it's too much. So again, it's very variable, and it depends on what you are trying to achieve and what you come in with. And then this is where it gets even trickier when you really start going down the rabbit hole, are the profiles. Everyone likes to talk about the profiles of the implants. So implant profiles can go from low, medium high, or moderate plus, and full or high profile. And extra.
Ultra high.
And extra, ultra high. And there are 3, soon to be 4, companies that manufacture implants in the United States. And all of these companies, and people have different reasons why they like any given company, and that's a super esoteric discussion that's not pertinent here. But all of them have different versions of these profiles. And the smallest, the lowest profile basically looks like a pancake. It's super flat. I've used them like on a handful of times, a lot of times in breast recon. Like there's times when I just need like flatness. But very rarely do I use that for a cosmetic patient. And then a medium profile or a moderate profile, that's going to give you the most natural sort of implant look. That's for someone that wants to have volume, but maybe doesn't want anybody to know that they have an implant in place. And then as you get to the mod plus or the high profile, and then certainly the extra high profiles, that's really what's going to give you more of that augmented appearance, which doesn't mean that it has to look fake or firm or hard, but it's going to have that appearance of being boosted, elevated. People will be like, yeah, she probably had a little something done. Like it won't be as secret.
Yeah, I mean, I got news for you. If the implants look great, they don't look natural.
Right? Like, I'm sorry. Like, natural breasts, I mean, God bless them. He made them. But, like, they're not, like, sitting high and perky in the average person.
Not. They just, if you don't want natural.
Unless you do, then implants might not be for you. But if you come in asking for implants and a natural breast look, those are kind of two, separate wishes.
Right.
But they still can be soft and they can still be really pretty and they can be versions of augmented appearing.
I like to call it naturally augmented.
Naturally augmented.
So it looks like it fits your body. It's beautiful.
Yeah.
It looks great. But like, no,
But
those are not
way
real.
too
Sorry.
pretty.
Yeah, they're just
to be natural.
They are not natural. It's okay though. It's quite all right.
It's totally okay.
Yeah, and everybody has a different look. This once again comes down to the fact that as a patient trying to find the surgeon that you want, you should look at the before and after photos because they all have a different look.
Yeah.
My patients have a different look than your patients that you've operated on have a different look than the patients that have been operated on by our colleagues. Everybody has a look that they're going for with breast augmentation. And based on what they do in surgery, it's going to produce a certain look.
Absolutely. The way you create your pocket, the style of implant you choose, whether or not you think someone needs a lift, all these things contribute to a certain look that clearly, one surgeon prefers and over another look. And that's not to say that every person's going to come out cookie cutter because every person's different. But there is going to be some similarity to the look of any given surgeon. But you can always come in and ask for a different look and they can work with you on that. But just know that you may end up getting a version of kind of what they tend to do.
Yeah, if the implants look like they are far apart on the chest wall on every one of the photos of a surgeon that you're looking at, you can guarantee that the technique that that surgeon uses will put your breast implants far apart and you will have a big gap and no cleavage. And if cleavage is something you want, keep scrolling and find the next surgeon who creates lots of cleavage.
Right.
That's sort of like, that's my hallmark is people always say, you always make really nice cleavage on your patients. It's been commented on by, surgeons. And even I remember telling you the story about how the Google bot thought that my medical before and afters were, pornographic and blacklisted my...
Too much cleavage.
Right. Too much cleavage for breast augmentation, which... is because I release the muscle. There's a reason why it does that. It's not a mystery of how I get that cleavage. It's just that a lot of surgeons aren't willing to do that.
Well, that is a question that comes up a lot because people are always very scared about having the implants that sit really far apart. And is it inevitable? There are a lot of things that you can do intraoperatively to get the implants close together. But there are some patients where unless you put a huge implant into them, you're not going to be able to get them as close as even you or I would like them to be because it does come down to where the muscle inserts on the sternum. The muscle is the pectoralis muscle. It starts kind of on the shoulder bones and then it crosses the chest and it inserts onto the sternum in the center of the chest. And if you have a very wide sternum or if the insertions are wide set, then it's going to be a little bit more challenging to get the implants super close together because these implants, and we didn't talk about this, but they're going under the pectoralis muscle. And so you are limited to a certain extent by where that muscle sits because you can't just obliterate it completely because then you'd have a uniboob. But there are different tips and tricks and things you can do. You can put in larger implants. That'll create more cleavage. You can do fat grafting to the central portion of the breast to give you a little more cleavage. There are some things you can do. But you're right. If every single photo on a patient, on a surgeon's before and after page has them far apart, then that's just how they
That's
like
what you're
them.
going to get.
But every once in a while, you do have a patient just, who may have that anatomy where it's a little bit more challenging.
In which case, what I do for those patients is I say, if I find that your muscle is not advantageous for creating the look that you and I have discussed, then I will do a sub-fascial augmentation.
Yes, that's the other option, is taking it from out of the muscle, getting the muscle out of the equation, putting it on top of the muscle, either under the fascia, which is the muscle covering, or on top of it, which is just under the breast tissue itself.
Which
and then
works
you can
great.
put them anywhere you want. Like, you are not constrained by the muscle. You can put them as close together as you want. So that is an option for that particular patient.
Right. And I tell my patients I'm going to do the best choice in terms of where the placement goes based on, a lot of patients say, I really want them under the muscle. I say, okay, that may not be the best thing for you. And I'll try to understand where their pectoralis major is and what it's doing. And I have them flex and all the things and that's why I think if you're looking at those before and afters, take a good hard look, because the chances are that's what you're going to get from that surgeon. And, again, not everybody's going to come to us for breast augmentation. In fact, I do so few primary breast augmentations. It seems like everybody needs to go get their implants wrecked someplace else, and then they wind up in my office. But the primary breast augmentation can be really nice, and if you nail it on the first go, boy, that's the last time you really hear about it for 10, 15 years.
Then it's a win. And so that segues us nicely into the pocket, or where to put it. So we were talking a lot about putting it under the muscle. That's the most common in general.
It is.
Is to put it under the pectoralis muscle. You can also put it over the muscle, which means that it's just sitting directly under breast tissue, but over the muscle. Or you can put it in a place that you reference, which is sub-fascial. The fascia is a connective tissue covering that sits over the pectoralis muscle, and you can separate it from the muscle. So you put it under the fascia, which means that it has a little bit more connective tissue covering on top, but it's still sitting on top of the muscle. The reason...
Did you say it was titting on top of the muscle? I think you did.
Did I? That was a
think you did.
total
I'm not
Freudian
sure.
slip. So
Hey, Sean, can you play that back for us? Because I think that I mean,
that the
I
implant
get it,
is titting on top of the muscle. Yes,
which
it is.
That's now a new verb. I think that was really clever.
Oh, thank you. I've been working on it.
Good. Well, what are your implants doing? Well, anyway, back to what we were talking about. About
placement.
Sub-fascial, sub-glandular, which is what it's called when it's on top of the pec fascia, or sub-muscular.
Or sub-muscular.
Those are your choices.
Options. And in general, if you have it sitting directly under the breast tissue, ideally you have enough breast tissue to cover it.
Yeah.
Because if you don't, you see the edges of the muscle more obviously, and you see the ripples and sort of the underlying anatomy of the implant. So
Edges of the implant.
Edges of the implant.
Yes.
Yeah.
Yeah,
Well,
because you can.
Well, I meant the ripples
rippling's
too.
like a big issue with
Yeah.
these implants if you don't have a lot of coverage, and that's really where the sub-muscular comes in.
Right. So if you don't have a lot of breast tissue, chances are your surgeon's going to prefer to put them under the muscle or subfascial. There are certain patients where you kind of have to go subfascial. I'll do that in patients that are bodybuilders or doing a lot of work, and they don't want the implants under the muscle because they work their muscles a lot. Yeah. So those are great patients for subfascial implants. In my tuberous breast patients, which is a whole nother podcast, go listen to that. They kind of have to go under the breast tissue in a sub-glandular position. So there are a few times when putting it under the muscle is not the best choice, but in general, that's where most of the implants do end up getting placed.
What about incisions? Should we talk about how to approach making the pocket? Whether you do it for mammary or periareolar or axillary, those are sort
transumbilical.
Does anybody still do that?
I haven't heard of a recent transumbilical in decades, because in order to put a transumbilical in, you kind of have to use a saline implant.
Yeah, that's where you use an incision in the belly button. Yeah. You tunnel up to the breast. Now, I just have to tell a quick story about that because, A, I've never done one and I don't plan to. I've corrected a bunch of them. But when I was a medical student at Cornell, I did a rotation at Emory University in 1993. This is a long time ago. And the tuba, the transumbilical breast augmentation, had just come out and was published in PRS. And it was the subject of our journal club article. And I had read the article, and when I got to Emory University, I don't have a lot of filter, as you know. It's been painful for you, I'm sure. But I walked into the OR, and one of the guys, I think it was Bob Wood, who's a craniofacial guy, said, "Did you see that article about transumbilical breast augmentation?" And I teed off. Like I talked about, like I was like a 30-year veteran of breast augmentation, talking about like it was the dumbest thing I could ever imagine.
Wow.
And I had no business to talk about it as I was nobody. But it just seemed so stupid to me at that time that I just went crazy on it. I was like, I can't believe people would do this. Like, it's so far away. Why would you want to? How are you going to control the pocket? Like, it was just out of like my just rudimentary understanding of what a breast augmentation was, that this made absolutely no sense to me. And then as I've gone through my entire career, it becomes even more
Yeah.
obvious to me about why this would not be a good idea.
So just don't come asking for transumbilical, because it's not going to happen. It's not a
Not
thing.
with us anyway.
No one does it.
I'm sure there's somebody who does
there's someone
it.
out
There's
there.
somebody who does it. It's not us.
It's not us. Transaxillary, similarly, not done that commonly, but there are people who do it.
I'll do it.
And I would
It's
say,
rare.
go to those people who do it, and it's
I don't
whatever.
love it.
I don't love it. I don't love it.
Why don't you love it? I have a very
Yeah.
specific reason why I don't love it. Why don't you love it?
I don't love it because I think it's harder to control the pocket. I think it's harder to control the IMF, or the place where the implant sits. And I don't love the idea of going through the armpit, which is like really dirty and gross. So I'm not a fan, and it seems a lot harder than it needs to be for the benefit of having an incision in a dirty part of the body.
Yeah. So I guess there are two reasons why I don't love it. I don't love the incision, just like you don't love it, not just for the cleanliness and the capsular contracture issues, because we believe capsular contractures I think it's due to two things: either a low-grade bacterial contamination or blood left in the pocket that irritates the pocket. But I find that the implants ride high. That
Yes.
getting a beautiful lower pole of the breast is very challenging through a transax approach. I'm not saying it can't be done, but in the patients that I've corrected that have had transax before I got to them and did inframammary or periareolar, they were all kind of riding high. And I did a bunch of transax as in the resident clinic in Pittsburgh, and I probably did maybe 30 of those myself, and probably assisted the other residents on 70, 80, 100 of them, somewhere in that neighborhood. And they all kind of rode high, and we would say, yeah, just put this bando on. We'd give them a breast band and tell them to push it down. They never went down. They were always riding high. The patients, I don't think, minded very much. They were fine with it. They sent their friends. But I didn't love them. I think that you have so much more control through periareolar or the inframammary incisions.
Right. And those are the other two incisions. So the periareolar means that you go kind of under the areola. I do that very infrequently. I do have one coming up. And the only reason I'm doing her like that is because her IMF, the fold, the inframammary fold, which is where I would usually put an incision. It's a small incision. It's hidden at the bottom of the breast. No one can really see it unless you're posing naked with your arms up. In this particular patient coming up, I can't use that incision because she doesn't have an IMF. She's almost like, I don't want to say she's flat as a board, but has very little breast tissue, and I can't even identify where her IMF is.
That's a problem.
So in those patients, using the areola, I can kind of come down on the IMF from above, and I'm less worried about trying to find. I can see it once I'm in there, but trying to identify it through the skin and guess where it might be is a little more tricky.
Yeah, and that's actually a common issue in many Korean, Chinese, Southeast Asian patients, where they don't really have a developed IMF. It's really common. And so if they don't have a lot of breast tissue that even gives you an indication of where it's going to wind up, you're right, then the incision is difficult to place. So then using a periareolar would make sense just from an aesthetic standpoint.
Yeah, absolutely. The reasons that I don't love the periareolar are getting a little bit less, and I think it relates to implant complications, which I think is a good place for us to go now, because we've referenced a few of them, and I think we should talk about what the complications are and kind of how incisions and techniques may affect it. So complications, in the beginning, there's always complications such as bleeding, like with a new surgery, and infection. This is a foreign body that you're putting in, it can get infected.
That's right.
And the thought has been that the periareolar incision has a little bit higher chance of becoming infected because it's right by the nipple, and it's hard to get the nipple completely sterile. It has milk ducts. It has a lot of stuff happening in it that makes it hard to get it totally sterile. And if you're trying to put an implant in adjacent to that, it's easier for it to get contaminated. Well, we have newer techniques. We have newer devices. We have these things called Keller funnels, which are like icing bags. You put the implant in, and it protects the implant from ever touching those surrounding skin as you're putting it in. So some of these techniques have allowed us to expand what may have been a contraindication to the periareolar incision. The other thing that can happen with implants long term, once you're out of the initial kind of initial postoperative period, is implant rupture. Less of an issue these days. Implants that are going in have 20-year warranties against rupture. That's how long almost every single implant company believes they should last for before you consider rupture being an issue. So they could theoretically rupture, but less and less these days. And then capsular contracture. Capsular contracture happens when sort of this layer of scar tissue forms around the implant. And when that happens, it can be a big problem. It could be a small problem, but sometimes it ends up being enough of a problem that you have to go back to surgery to revise it.
Correct.
And as you alluded to, one of the reasons that we think capsular contracture occurs is because there's a light seeding of microbacteria inside the pocket at the time the implant's placed and just causes this chronic irritation that eventually results in capsular contracture. So that's another reason I kind of tend to stay away from the periareolar just because, if I don't have to use it, why would I?
Right, but if you do have to use it, it's not the end of the world.
It's not the end of the
Use
world.
the Keller funnel, betadine irrigation, all the things that we do that really make this procedure very safe. And the rate of capsular contracture, I think, has been pretty steady. It depends on the study that you read, but it's anywhere from 5 to 15%. And it does happen,
accurate.
and I just I wish it wouldn't. We all wish it wouldn't, but I see it.
Yeah, it definitely happens. And that's another thing that makes a lot of us use the sub-muscular pocket. So there are studies that show there's a decreased chance of capsular contracture if you put it under the muscle. And I think for a similar reason. If you're putting an implant directly under the breast tissue, it's exposed to breast tissue, breast ducts. There is some microbacteria that lives in those ducts. So it could be getting an exposure to them as well. And so that's why if I can put it under the muscle, I prefer to because it does have a decreased chance of getting capsular contracture. And capsular contracture, we have a whole podcast on it.
Yep.
But basically, it can make that breast get firm, hard, painful, and disfigure it and make it look different than the other side.
Yeah, we want to try to
We
avoid that if possible.
avoid that if possible.
But if it happens, again, it's not the end of the world, but it does mean more surgery. And I tell everybody who's getting breast implants that breast implants are like a heart valve or a hip replacement. Prosthesis, they're not meant to last forever, and you're going to have surgical maintenance on them, and you can have issues that. So when you sign up for it, you got to kind of know that's part of the deal, and it's not because of any problem with your surgery. It's part of trying to get a medical device to live in the human body, which works really well and does have its issues that you need to deal with.
You do, yeah. It's not, you're not putting these in and forgetting about them.
No.
They do require maintenance. If you're getting to that 20-year mark of your warranty, maybe consider replacing them. That being said, I find most people end up replacing them before that time for cosmetic reasons. Time, age, baby, gravities, weight gain, weight loss, all reasons that they may need to update their implants. And then the other thing that's really important to know, you can always take your implants out anytime.
Yep.
At any time, you put them in electively, you can take them out electively. That being said, your breasts are going to look a lot different. Having an implant in for any given period of time will stretch your skin. It'll thin your breast tissue, and it may not snap back to even what it looked like before the implants were in place. So, yes, you can take your implants out. You might not look how they look afterwards.
Yeah,
So just
that's true.
one little thing to keep in mind.
In general, very high satisfaction operation.
In general, very high satisfaction.
Patients are very into it. They get a lot out of the confidence that they get, and it's a very satisfying procedure. I love doing breast augmentation. I love I have this whole niche specialty of fitness people with their breast implants, which are challenging. But
Super challenging.
I like going after those and trying to make it work because I think there's just, a lot of my experience allows me to kind of treat that stuff. And, you probably have a lot more experience with disaster reconstructions and
Yes.
problems in weight loss patients. So, I know you have your niche specialty on those as well. So, if you're going to get breast augmentation, look for somebody who's, board certified in plastic surgery and can really show that they've done things like what you need done. That's kind of the key.
Yep, absolutely. And then just one last tidbit before we head off. We did not talk at all about patients that also need a lift with their implants.
No.
We'll do that as a separate 101, but just know that that could potentially be you. Listen to your surgeon, take their advice. If they say you need a lift, you probably need a lift, but we'll do a separate podcast about that coming up.
Wait a second. There's
What?
more.
Oh, wait. There's more.
What does this cost?
Oh, okay. Well, depends where you are.
This is zip code dependent.
Depends who you go to.
It's country dependent.
And saline implants are cheaper than silicone implants. You can listen to the person on the radio and go get your $3,500 saline breast augs done under local in a garage, or you can go to the most expensive, exclusive plastic surgeon in, Beverly Hills, Manhattan, and pay $35,000. So it's a whole range. I think average in Beverly Hills for a somewhat experienced plastic surgeon, primary breast aug is probably anywhere from $12,000 to $18,000.
Yeah, probably.
Yeah.
I think that's probably the average running price.
Yeah.
And it does depend on what you're doing. I mean, I don't have like a standard price for breast augmentation. Like
No.
For me, just on this day of 2024, it ranges anywhere from $18,000 to $30,000 for a breast augmentation.
Right.
And there are some that are more difficult than others. They cost more. There are some that are less difficult and they cost less.
Yeah, and then there are also plenty of places you can go to in Beverly Hills or outside of Beverly Hills within Los Angeles and get a breast augmentation for $7,500, $8,500, $9,500, and you can still have a great result. So, again, befores and afters, do you like what they can do? Do you like their work? Do you like them as a person and as a surgeon? Do you trust them? And if so, if you can answer yes to all of those and they're in your budget, great. Go to that person.
100%.
So I think that was our rambling, bumbling way of trying to condense this whole topic into a 101 for breast augmentation.
I thought
If
it
you
was
have
good.
more,
I'm
if you have more questions,
going to give us an A- on that. It was really
oh,
good.
thank you. I
Very
think
good.
A-.
Yeah.
But if you do have more questions and you want more of a deep dive on any one of these topics, go look it up in the podcast. There's a
We have
podcast
so many episodes
for
about it.
anything you could possibly ever want to know. And with that being said, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.